All righty. What's macrocytosis? Defined by an elevated MCV, mesothelial volume, and normal's 80 to 100. So anything greater than 100 is macrocytosis. Here you have macroovalocyte. Here's one of the key things, right? In microcytosis, you're going to need to be able to identify graphics, right? A hypochromic microcytic cell next to a lymphocyte. You're going to need to be able to identify. That's a graphic you need to know. Here's target cells. You need to know about those and their implication related to thalassemia, among other things. So in microcytosis, you're going to need to be aware. Macrocytosis, they may show the graphic, but it's not going to get you there. You're going to see these. They'll either give you levels or not, which they don't. These hypersegmented PMNs, when you see those, this is either B12 or folate deficiency. And I'm cautious, ambivalent about making a statement like this because students say, oh, stop making fun of us. We can't help it. We're heme challenged, whatever. But my point about these hypersegmented PMNs are the knee jerk for a student is, here we go, we got a leukemia question. And the answer is no, right? There's our rods, these are lymphoblasts. That's not what they are. These are hypersegmented PMNs. So they report the high MCV, they show you these pictures, and then there are the derivatives. And there's one exception to the rule here. Macrocytosis for the boards really is B12 folate, but the only exception, as you can see here, this is cirrhotic liver. It's liver disease causes macrocytosis. When we talk about liver disease later this morning, we'll get into a little bit more of the particulars. But the bottom line is that's what this question was. Patient presents recurrent episodes of mid-epigastric pain, rating to the back. That's recurrent pancreatitis, CBC, reveals a elevated MCV. What's the most likely cause of the pancreatitis? It's the MCV in this question that is telling you that this patient is using alcohol. The high MCV doesn't go along with gallstones, high trigs, et cetera. B12 deficiency does certainly go with a high MCV, but it doesn't really have anything to do with a cause of the pancreatitis. In this instance, has a high MCV, you get B12 folate levels, and that is the footprint of a patient who is using alcohol. The question comes up is, why do you get macrocytosis with alcohol-associated liver disease? And it has to do with cholesterol esterification. And later on, I'm going to say fatty liver, fatty red cell membranes. That's just the way to think about it. You get fat deposits in the red blood cell membrane. That's why the cells get enlarged in patients with alcohol-associated liver disease. All right, so let's come back. The main curriculum here this morning is B12 and folate as it relates to macrocytosis. And by the way, again, the macrocytosis associated with liver disease does not give you these hypersegmented PMNs. That's purely a B12 folate phenomenon. So what you're going to see this, major derivatives. What are the major takeaways from the presentation or what you need to know and the things they focus on? B12 deficiency is associated with neurologic manifestations. Folate deficiency is not. And what's the lesion? This subacute combined spinal degeneration combined. What does that mean? Yeah, both dorsal sensory and lateral tracts weakness. So they're going to present with abnormalities of proprioception, gait abnormalities. So when they give you a patient with macrocytosis, and they have sensory and or gait disturbance, that's the language of B12, not folate. And that's what this question was, the neuromanifestations, take home number one. They gave you anemia, paresthesia, ataxia. That's the whole package. They got you to B12 with the elevated MCV and the hypersegmented PMNs. They took a supplement that corrected the anemia, but not the neurologic symptoms. So I just told you, right, that B12 is the cause of the neurologic symptoms. And in this instance, we fixed the anemia, but in fact, they needed cobalamin, B12, to fix the neurologic symptoms. That's a lovely distinction they're going to like to make. And we'll get to in a second why the anemia get better, but the neurologic symptoms didn't. All right, so that's major derivative number one. Don't want to beat that to death. Derivative number two is duration. So nutritional deficiency of cobalamin, rare, compared with folate. And the reason for that, again, the liver stores B12, you'll lose only a small amount, and you do the math. If you have 4,000 micrograms and you only lose 2 a day, deplete B12 from the liver, it's 5 years. It's a long process. If you stop eating now, it won't be until you're in the second year of your residency or thereabouts till you're B12 deficient. And it's compare and contrast with folate deficiency, what can happen in a matter of just weeks to months. It's a shorter duration. There's no specific timeline on that. And that's what this question was. Loses the job 4 months ago. That was the key thing. Using alcohol, they're drinking instead of eating, lost 12 pounds. 6 months prior, the MCV was known to be normal. So really, this is a patient who became macrocytic in a period of just 6 months, and which of the following is most likely diagnosis. This was a B12 deficiency versus folate deficiency, and the short time duration made it folate deficiency. In terms of takeaways, major derivative number 2, folate deficiency is more of a subacute issue compared to B12. All right, then it's the Heme. This is major derivative number 3. It's the idea of B12 as a cofactor, and this is just the short version here. So what does B12 do? Let me start down here. So you have methyl tetrahydrofolate, a methylated group. B12 is a cofactor to transfer that methyl group from homocysteine to methionine. That's what it does. And then the result of that is the active form of folate, tetrahydrofolate. You can bypass the B12 role, just take active folate, and you can fix the anemia, but you haven't fixed the neurologic symptoms. That's the take home there.